Thanks, John, for this very kind introduction. I really appreciate it. In the next few minutes, I would like here to introduce you to novel aspects of the immune system becoming dysfunctional. And before I do that, I really would like to thank the organizers to have me here speak about systemic dysfunction of the neuroimmune processes, in stark contrast to the usually classical approaches, mostly focusing on neuroimmune processes at the lesion site itself. So the immune system has been discovered foremost by its capacity to fight off bacteria and viruses. Now, how to destroy these invaders without harming the body? This requires the capacity to discriminate between self and non-self. So a complicated process which needs to be orchestrated all the time. So the immune system has been considered foremost a defense mechanism, but not only. It's also relevant to enable physiological responses and also to allow for repair. So there's a system, the immune system in place, which is orchestrating immune responses to be appropriate, to do basically the right thing at the right time. And in the following, I will here describe three main features of how the immune system can become defective after spinal cord injury, then resulting in maladaptive or skewed immune responses as the system supposed to have control basically lost control. So as a brief overview, I will introduce you here to the spinal cord injury immune deficiency syndrome with specific relevance also to drive infections, here illustrated by the spinal cord injury associated pneumonia and also the consequences of such a pneumonia here on the injured spinal cord itself. The second maladaptive immune syndrome I would like to introduce to you is the secondary autoimmunity, which can develop after spinal cord injury. And I will also briefly touch on impaired resolution of inflammation after spinal cord injury as well. And then I will close giving an outlook on the clinical relevance on why it is actually important to study these maladaptive here systemic immune syndromes. So let's get started. So with the spinal cord injury-induced immune deficiency syndrome, and I take you here on a journey which is now about 2.5 decades, or almost 3 decades, 2.5 decades, doing this here, following this research, and starting point getting into that is a clinically relevant, prevalent, but largely unsolved problem that infections are to this day the main cause of death, both after acute and chronic spinal cord injury, and also infections are independent risk factors for poor neurological and functional long-term recovery. Just to gloss over some of the data here, we can see here that patients color-coded in red versus green. In red would be the patients with acquired pneumonia with infection are doing worse with regard to recovery, as here assessed by gain of Asia motor score points as a difference from baseline. This is even also present here in incomplete patients and further translates also in functional capacity, basically disability of those patients. Again, red versus green, you can see that these patients with acquired pneumonia already at discharge are impaired, and this remains to be present up to 5 years after spinal cord injury, indicating that the patients are not able to compensate for what is supposedly be a secondary hit to those patients. So in summary, I guess even spinal cord injury is a catastrophic event for the patient, and of course also mostly the families, of course, as well. There is the bad luck which can even come after such a catastrophic event, which is the development of infections. Well, why should there be a neurogenic imprint on here immune function? Well, because the central nervous system controls the immune system by at least 3 different pathways, as indicated here: the sympathetic nervous system, the stress axis, the hypothalamic pituitary adrenal axis, and also here by the vagus nerve. And you can see here these different immune here compartmentalized organs are differentially here innervated along the neuraxis. What is now a spinal cord injury doing? Well, a spinal cord injury causes a sympathetic denervation, or in anatomical terms, or preganglionaric injury. And depending, of course, where the lesion will be, there will be complete different than denervation profiles emerging. Is there now evidence for such a maladaptive immune response? Yes, there are many symptoms being identified contributing to an immune deficiency syndrome. I just share with you a few. There's early cell depletion, what we can see as illustrated here in FACS analysis, where we compare high versus low thoracic injuries, and we look here at B and T cell progenitor cells, and you can see that there is a cell depletion, particularly in these high thoracic injured animals compared to those low thoracic injured animals, and here as compared to controls. This is just a further illustration of that. But it's not only a number game, it's also about function. So cells are not able to perform anymore as they should do. And one of the major features of the immune system is that you have patrolling here, immune cells trafficking throughout the body. And we were interested to see whether this patrolling or this trafficking is also affected. And for that need, actually, splenocytes have been taken and labeled from naive animals and then transplanted through the tail vein back into animals with either high thoracic or low thoracic injuries, and then compared here then to controls. Then these cells were allowed to populate for 24 hours, and then we were able then to see whether these cells were homing to lymphoid organs differently. And this is illustrated here. These are the different lymphoid organs along the neuraxis. And I would like to draw your attention here on the red versus the violet bars. What you can see here, particularly in this red here illustrated high thoracic injured animals, that there is a particular profound problem or deficit with cells homing to these here lymphoid organs. So besides immune cell depletion, there's also impaired immune cell traffic, which is a prerequisite for immune surveillance and homing, which is impaired in a lesion level dependent manner, which is then also allowing for the term neurogenic. So this is nice to note, but is this really functionally relevant? And to learn more about that, here we performed a bed-to-bench-side reverse translational approach, where we developed a controlled model of experimental pneumonia, basically superimposing animals with spinal cord injury and giving them here pneumonia. This you can see here. Animals are basically inoculated with 500 colony-forming units of Streptococcus pneumoniae. This will induce here a pneumonia as such, and then at the end of the experiment, we will basically take out the lungs and here count the bacterial load based on the number of colony-forming units, which are basically being detected in those lungs. And with that, we can compare spinal cord injured animals with either high or low thoracic lesions, and even control for other confounders, like, for example, aspiration or post-aggression syndrome, like for example surgery or also anesthesia. So if we here look at the numbers of bacteria, or the bacterial load, so we use pneumonia severity as a net assay for immune function, we can see that after high thoracic injury, these animals show remarkable increase accumulation of bacteria compared higher than compared here to the low thoracic injured animals. And in the sham here control, all besides one animal have been able to clear off the bacteria. So with that lesion level dependent effect, I guess it's fair to say that or to quote that spinal cord injury is not only causing the more obvious motor sensory paralysis, but also is able to trigger an immune deficiency, which is driving the susceptibility to infections. Well, this is a mechanistic study done in animals. Is this relevant for human SCI? And to study that further, already quite some time ago, we launched a Sentinel study, which is a prospective study comparing signs of immune suppression with actually development of infections. And we compare here patients with high thoracic injuries with those with low thoracic injuries, and furthermore here to patients with vertebral fractures alone without any affection of the spinal cord. And the results are illustrated here. In brief, the study has, of course, completed now enrollment by now. We have analyzed the data comparing high injured patients with low injured patients and compare those to vertebral fractures. And the primary outcome parameter has been whether monocytes become deactivated. There is an HLA-DR assay, which measures the amount of HLA-DR expression on monocytes as a marker of activation, which has shown to be also predictive in other immune suppressive models to basically predict infections. So I will not go too much into detail, but it's the facts here, algorithm basically labeling for monocytes, specifically gating for them, and then here assessing the mean fluorescence intensity. Then with calibration beads, one is then able to calculate back to the amount of antibodies bound per cell, and this is basically indicating the amount of MHC class 2 or HLA-DR molecules being present on those cells, again indicating the activation status. So if you now look at these results over time, we look here early on the left side here to up to 10 weeks after spinal cord injury. And I would like to draw your attention here on the red triangles versus the green. We can see, this is a logarithmic scale, that very early on the highest level or the high level complete group here in red is suppressed the most and actually remains suppressed even here compared to others throughout. And the nadir is something like about 2 to 3 days after a spinal cord injury. So is this sufficient to drive infection susceptibility? And to get a better answer to that, we extended the analysis and looked for whether early onset infections are particularly enabled by patients with, or seen in patients with low monocytic HLA expression. And this is now here, this analysis I would like to share with you. Early infections are here color-coded with these red dots. Again, these in green would be then patients without any infections. And you can see that particularly those with low HLA-DR expression, indicating deactivation of monocytes or immature monocytes, are the ones which get infections early, and this is actually the group which remains here prone to be immunocompromised actually throughout. So this verifies monocytic HLA-DR as a candidate surrogate parameter on monocytes to predict infections. We extended the analysis, looking also for as secondary parameters for other features associated with impaired immune function, and we detected that also over time there's a relative hypogammaglobulinemia, basically a protein loss, which also results in mostly secretion of, likely urinary secretion of these immunoglobulins, and this is a rather symmetric effect affecting both IgG, IgM, and IgA, and of course IgA is a particular relevance with regard to mucosal immunity being also here suppressed. So what does it mean? It means that likely besides cellular features, cellular symptoms contributing to immune deficiency, that there are also non-cellular aspects contributing or adding to this immune deficiency, making it a combined immune deficiency. So I would like to summarize the first here part with regard to the phenotype of this neurogenic imprint on the immune system. Spinal cord injury disarms the systemic immune cell function in a lesion level dependent manner, affecting cells of the innate but also adaptive immune system. As underlying mechanisms, we and others have identified immune cell deactivation, propagated cell death, hypogammaglobulinemia, impaired cell migration, but also impaired cell homing as a basis for cell surveillance. So this immune deficiency is clinically relevant and impairs the ability to mount an effective, appropriate immune response, thereby increasing the susceptibility to infection. And what would be now the clinical consequences of that? We would like to develop clinical hands-on score, which would help us to identify those patients being at risk and then triage them to other treatment algorithms. To, however, then interfere with the development of those infections, we foremost would like to understand what is really the underlying mechanism of this immune deficiency, which would help us again to find ways to interfere with it. And I guess this is still quite an accurate here drawing. So what happens after spinal cord injury, that there is a sympathetic nerve activity originating from below the lesion site here, ascending as afferent sympathetic drive, and then able here actually to branch off because there's no supraspinal inhibition anymore here to the adrenal gland and also here to the spleen. And this is here beautiful work here done by the Popovich lab, which shows that also the architecture of here the sympathetic innervation below the lesion site in the condition of lack of supraspinal control is becoming altered, as you can see here by these interneurons becoming almost formed like in a chaotic way. So how can we then kind of frame that from a clinical perspective? We know already on the motor system that there can be pathological reflexes, which are illustrating basically the fact that there is not any more supraspinal control. And this would lead, if you, for example, scratch on the plantar face of your foot, would then lead to a Babinski, meaning the big toe going up. We consider that as a kind of an analogy here, that this is for the autonomic nervous system, that this sympathetic nerve activity can create also aberrant here consequences on the endocrine system, but also on the immune system, in a way then forming a simpatico-Babinski, which is transmitted here towards these respective here drivers of homeostasis. So in a way, just a full bladder or full bowel or just pain is able then to trigger these sympathetic bursts, which is in a way considered a false alarm, and then triggering this false fight or flight response, which irrespective or independently has been shown to be associated with a shutdown of the immune system. So what would be now a mechanism by which this sympathetic nerve activity, again being triggered by full bladder, full bowel, can drive this immune deficiency? And if you just take one step back and look at the major characteristics of this immune deficiency when it occurs, it's quick, it's acute, it's neurogenic, it's lesion level dependent, and it's also systemic, affects the entire body. There are not many organ systems which can moderate these effects, and very high on the list is, of course, then the adrenal gland. The adrenal gland also receives here preganglionic here sympathetic innervation, and is pumping out classically catecholamines here from the medulla and here from the cortex, steroids, which are the main immunomodulatory or even immunosuppressive hormones being produced by the body. Well, to continue further, is there any reason to believe that there's a maladaptive neuroendocrine response after spinal cord injury? Well, we wanted to learn more about it and looked into that during the acute phase during the first 3 days. And here color-coded red versus violet, you can see here high thoracic versus low thoracic injured animals. And very early on, within 24 hours, these animals drop here with no epinephrine levels, and this remains consistent over the first 3 days. And this is probably not too much surprising, because this is what we also see in the clinic when patients will need vasopressor support to keep their blood pressure up. What now about the other hormone being produced by the adrenal gland, the steroids? Here we measured corticosterone, and what we see is that in high thoracic injured animals, we see by contrast an increase of steroids in the high injured group. And when we got that back, we kind of thought, well, probably this because these animals are likely more stressed. This would be then due to an activation of the HPA axis. But when we had a closer look, it actually turned out to be not the case. When we looked for ACTH, we saw that this is even downregulated here in these high injured animals compared to these low thoracic injured animals. What does this now mean? This means that this is not an anterograde activation here from the hypothalamus or pituitary gland to the adrenal gland. By contrast, this is actually a hypercortisolism which is produced by the adrenal gland itself, which then results in a compensatory downregulation of ACTH. So this is a primary hypercortisolism, we would say. In a way, the adrenal gland becomes here agnostic or is doing stuff basically on its own. So this maladaptive neuroendocrine response originates from the adrenal gland, again, escaping the control here from the central nervous system. Can we now interfere with this endocrine dysfunction? A priori, yes, this would be possible, for example, by here blocking or shielding sympathetic bursts reaching the adrenal gland, basically keeping this false fight or flight response away from the adrenal gland. How can you do that? Well, one can do autologous adrenal transplantation, which would mean that you remove the adrenal glands from their localization on the pole of the kidney, transplant them a little bit more forward, and then they will keep the basically the humeral support. The vessels remain intact, but the nerve innervation to those adrenal glands become blocked. So to now investigate whether this is doing anything with regard to infection susceptibility, we here use the complementary model, spontaneous here pneumonia, also showing that very early after spinal cord injury, particularly the high thoracic injured animals are mostly here affected by getting here a pneumonia. And when we now perform this autologous adrenal transplantation, again, this is a kind of a shielding surgery, the animals have been showing a dramatic decrease of this bacterial load. So we think that this may be a mechanism even to look forward to develop non-antibiotic strategies to treat infections in those patients. And as you know, spinal cord injury patients are anyhow plagued with early on antibiotic resistancies, and also it should also be said that antibiotics given preventively are not actually doing the job. After acute CNS injuries, they are not preventing infections. So to summarize what I would like here to convey to you with regard to mechanisms, these neurogenic mechanisms of this immune deficiency, it appears that a low thoracic spinal cord injury does not allow this here spinally generated sympathetic nerve activity to ascend high enough. However, if the lesion is high enough, for example, after high thoracic spinal cord injury, this sympathetic overdrive can actually reach high enough to branch off then to reach the adrenal gland and also immune organs. If we then interfere, however, with this sympathetic drive reaching the adrenal gland, as I just said, by a shielding surgery, we are able to restore immune function, net function. So in a way, blocking this maladaptive sympathetic neuroendocrine reflex can restore host defense. So another way to learn more about this is, of course, then also to ask why is there in the clinic, why should there be impaired recovery? How does this work? How does the injured spinal cord know about the pneumonia? And to here learn more about that, we reapplied this experimental model already introduced to you earlier, where we basically superimpose animals with spinal cord injury here to controlled pneumonia. And of course, it should be also said that with the data I showed you, with the clinical data, this, even though being large data sets, multi-center data sets, they can only provide us here with odds ratios, basically likelihoods of impaired recovery. They cannot indicate causality. To prove that causality, whether infections are really causing impaired recovery, one would need to do prospective clinical trials, which is, however, unethical, because you, of course, cannot let people go with a pneumonia untreated and then others without pneumonia. The other way would be to apply animal models and where you can then control for various factors. And this is exactly what we did here. This is the design. We have here contusion injury in mice. We inoculate bacteria into these animals as shown earlier, and then we follow up on those animals over time. There is an effect here on locomotor recovery. early on. I should here also indicate that the inoculation has been done at 3 days. And if you look here for 4 weeks, here the recovery is blunted. However, we also wanted to know whether long-term recovery is really affected, or whether these animals cannot compensate for that basically impaired recovery later on. And so we added additional cohorts with longer year survival, 8 weeks, and here corroborating the effect, the detrimental effect of here acquired infection. So this locomotor impairment persists. So I guess it's fair to say that a spinal cord injury can be considered indeed as a second hit, for which the animals are unable to compensate for even later. So being a very robust effect, of course, the question then is what is happening here at the lesion site? What neuropathology may really entertain this fear of functional impairment? And here we looked here at the tissue of these animals, and what we could see is already very early on in these animals with acquired pneumonia that the lesion looks quite different. This is a pearl stain, here we see not only a larger lesion deposition, we see also here ferric iron being placed as well. This is just a quantification of that. So in medical terms, what we see here with this more extensive here blood products being present, this is a so-called hemorrhagic transformation. In a way, this is a rebleed of the old lesion. And we wanted to know also whether more toxic iron components are also here deposited. So we looked here for ferrous iron deposition with ferritin cells, which is very much mirroring that what we already saw with the pearl stain. So we see two things: more extensive loss of tissue integrity, but also then toxification of the tissue by really loading that tissue with toxic iron. And I would like to draw your attention also to here, this what we see in these animals with pneumonia also quite often, that even remote from the lesion there, I would say, I call them satellite bleeds. Even in more distant regions, we see here this kind of pockets here with iron. So can we more systematically assess these here remote changes after pneumonia? And this is here a quantification of that, where we looked for distance of bleeds from the lesion center, again, red comparing animals with pneumonia with those without. And you can see here, particularly in these more remote areas, we see actually more bleeds in these animals with spinal cord injury. This is another illustration. This is cumulative data, kind of verifying that in comparison to SCI only, if there's on top of that a pneumonia on board, you will see more of those bleedings here in these remote areas. So bleeds are known to be neurotoxic, so of course, then the implication of the question also is whether the circuitry, axonal circuitry, can be affected, whether there are axonal changes. And to address this question furthermore, we applied here a design to check for axonal dieback, which works like that, here illustrated as a design, here labeling here the sympathetic nerve as such here, and looking at that here at the lesion site, and see how here the nerve actually is how the labeled axons are basically behaving over time. What we see here that as a consequence of acquired pneumonia, these axons retract and far more than here in case of a spinal cord injury only. This is just a more contrasted image here with as a dark field image. So yeah, also we see more axonal dieback, which can be considered as a hallmark also of a pronounced axonal degeneration in those animals. So what I showed you is quite a profound change with regard to the lesion milieu. With the lesion milieu as a consequence of this pneumonia, we of course would like to know more about what type of specific cascades are triggered here due to this pneumonia, and for that need we run here bulk RNA sequencing. As you can see here, these pneumonia animals, or the spinal cords of these pneumonia animals, are quite different, indicating their specific here signal pathways being up or down regulated. And we would like to dive into that more to learn more about even potentially druggable pathways, which may help us to attenuate then this spinal cord injury associated pneumonia-induced neuropathology. So I would like to summarize this part with regard to the neurogenic immune deficiency. It's clinically relevant. We see a neurogenic effect being lesion level dependent. We see also immunosuppression even into the chronic phase. In particular, in the chronic phase, we see qualitative changes. So cells are not really able to do anymore what they have been able to do before. It's not only a numbers game in terms of cell numbers, it's really an impairment of cells. The animal model, what I showed you, is proving causality. So an acquired here pneumonia is impairing recovery by means of propagated neuropathology, and also inducing axonal pathology, as shown with this dieback data. So going forward, we would like to rescue outcome at risk and also inform early clinical decision making by developing HERO scores. Monocytic HLA-DR has been verified as a candidate to possibly predict infection, and this would then enable us to already identify patients early and hopefully also becoming then able to treat them differently in order to prevent these infections to occur. What it also means is that classically compartmentalized approaches to the lesion side, which we have done as a field for a long time, ignore major denominators of neurological recovery. So what should we do then? Should we just boost the immune function as good as we can to fight off these infections? And probably this is not as simple, because even though if you would boost the immune system is still not supervised anymore by the central nervous system, and with that we may run up into even additional problems, such, for example, the development of secondary autoimmunity. Is there such a thing like secondary autoimmunity? Yes, there is, and actually the most consistent or the most robust data about it has been developed by the Phil Popovich lab, also even attributing a physiological effect to those antibodies. So what you can see here, nicely shown, these lymphoid follicle-like here structures composed of B cells and plasma cells producing antibodies. These antibodies are also synthesized in areas here of complement deposition by itself, being capable to drive with that also degeneration. And if you take the serum from those wild-type animals with spinal cord injury and inject that into naive mice, you can see here this profound neurotoxicity being developed. However, if you take serum from just sham animals, there is no toxicity here being developed. Even more further extended with here a loss of function experiment where B-cell deficient mice have been included. One can see that these B-cell deficient mice do much better after spinal cord injury, and by contrast, these wild-type animals show earlier abrogation and just reaching lower levels here of functional recovery, qualifying with that as a potential here rehabilitation confounder as being transmitted by the development of antibodies. So despite now episodical notion of autoantibody synthesis in human, it remains so far unclear whether we see also after human spinal cord injury de novo autoimmunity development. And to shed some more light on that was the main task of the silence study, which is still ongoing. And a part of the silence study is also the reassessment of here serum samples from the Sentinel study. This is a collaboration done together with Romana Höfberger, a neuropathologist in Vienna, Austria. And here we tested sera from patients after spinal cord injury and compared those to vertebral fracture controls over time. And Romana, who is also an expert in autoimmune encephalitis, trained with Joseph Dalmau, extended the classical test assays used for diagnosing autoimmune encephalitis here to the spinal cord. She actually developed this tissue-based assay of the spinal cord, here also then incubating sera of patients overnight. And what you can see here is that in patients with spinal cord injury, in a subgroup of patients with spinal cord injury, we see over time developing, compared to controls, a dynamic signal, which is here replicated by many patients, mostly here targeting here this particular area. And this is the area of the substantia gelatinosa, less myelinated area, but characterized by high synaptic density. Here we see also a crucial area for sensory motor integration, or also for proprioceptive input, but also possibly also this is the region where neuropathic pain can develop. So this is the first assay. We can check with that whether in the sera are antibodies detecting spinal cord epitopes. The second validation assay is a cell-based assay using DRG cells, also co-incubating here with sera from patients. And what you can see here is in control patients, there's really no binding or kind of no binding here to these DRGs. However, in some patients, we see profound binding, like here, for example, in this low thoracic spinal cord injury patients, complete patient, we see here antibodies detecting these here DRGs, and very nicely also showing here membrane binding. So if you have a more here then systematic analysis of the entire cohort being investigated, the group of spinal cord injury patients, and here the control group, we can see in these Venn diagrams color-coded basically those patients being double positive, being positive in the tissue-based assay, but also in the DRG assay positive, in the cell-based assay. Here, this would be then just TBI positive, but not cell-based assay positive, and so on. And I would like to draw your here attention to these double positive cells. Only in the spinal cord injury cohort, there have been here double positive here patients, so 16%, a subgroup. None of those patients in the control group showed actually double positivity in these assays. So what does this now mean? Of course, this is early days, but it appears that a subpopulation of spinal cord injury patients can develop autoimmunity, which is directed against CNS antigens. And quite in analogy, as we already know from paraneoplastic syndromes, in a way, patients with tumors also can produce aberrant antibody here responses. Very likely we see something also here developing after a traumatic spinal cord injury, again affecting only a subcohort. But these paratraumatic syndromes may also be a chance here for personalized medicine to improve outcomes. So very brief, yes, we see also here in human spinal cord injury, B cells and plasma cells here accumulating here mostly during the post-acute phase, and these antibodies produce also IgG and IgM. These cells also co-localize to areas of activated complement deposition as illustrated here. So very much matching what has been shown in animals earlier. So let me summarize here briefly. After spinal cord injury, there is a spinal cord injury immune deficiency developing, which is operated by a neurogenic pathological neuroendocrine reflex. This immune deficiency is not just an epiphenomenon, it actually is able to drive infection susceptibility. It enhances, for example, pneumonia severity. The pneumonia itself is also not just an infection. As in an able-bodied individual, the pneumonia is driving here axonal damage or affects here the lesion site, extends the lesion significantly, basically acting as a disease modifier. Also, we see after spinal cord injury in a subgroup of patients the development of a secondary autoimmunity, which may give rise to paratraumatic outcome syndromes. With that, I would like to touch briefly on the last here, maladaptive syndrome related to impaired resolution after spinal cord injury. Still, to this day, in some textbooks, you still will find that resolution is just a passive phenomenon, basically due to the disappearance of local chemotactic stimuli or the reduction of pro-inflammatory stimulators or mediators. This is for sure overcome now by a more recent concept indicating that resolution is already programmed very early on with the onset of inflammation and is requiring specific biochemical pathways, which then result here also in the synthesis of pro-resolving mediators being crucial to to perpetuate wound healing. So it appears that these pro-resolving mediators could be of particularly relevance in pathology where non-resolving inflammation or chronic inflammation is part of the underlying pathophysiology. So now what about human spinal cord injury? If you look here at the chronic spinal cord injury site, as depicted here, you can see already the lesion has been demarcated and the tissue debris has been removed and the cyst has been formed. But if we look here close here to the core, we can still see a number of remaining macrophages hanging around, and even more in the rim phase. Still also here we can see an accumulation of macrophages being there for a long time. And importantly, these macrophages are not just hanging in there, they also produce oxidative catalyzators, P22-FOX or NADPH, which then can produce oxidative damage also in neurons, which in turn then will result into the deposition of oxidized phospholipids, which we can then see or make visible with EO6. And you can see here this depositions here. This is a very unhappy neuron about to die. So this non-resolving inflammation is associated with oxidative ongoing injury. So can we map impaired resolution after spinal cord injury? Learn more about that, which cell type is mostly affected. So these are resolution indices. Resolution index is basically capturing the time from a certain cell population reaching maximum numbers to the time when these numbers have been reduced by 50%. And here you can see different cell populations being demarcated. Here the quickest one being cleared from the lesion site are the T lymphocytes, followed by the B lymphocytes, and in a way the microglia macrophages are the kind of the coach potatoes. If we then further even illustrate it as a resolution index, again, this is the time passing until the number of these cells have been cleared by 50%. You can see a remarkable, actually a difference also relating to different dwell times of these cells being present at the lesion site, and likely referring to complete different also resolution receptor repertoires on their surface. So resolution is disturbed after spinal cord injury. You saw this image here also after human spinal cord injury. Can defective resolution now in a way be rescued? To test this hypothesis, we took advantage of learning more about the resolution agonists, which are synthesized by macrophages, and the group here of myrcins are key. They have been here developed by a mentor of mine, Charles Sirhan, found by Charles Sirhan in Boston. So is this myrcin synthesis by any means affected after spinal cord injury? And if you look here on lipidomic data, looking for myrcin synthesis pathway markers, we can see that myrcin is actually not induced over the first 7 days. So the resolution program also only starts here of macrophages only starts with some delay. And this then identified our also treatment time window. We are kind of substituting the missing myrcin over the first week, and we wanted to know whether we can be immunomodulatory with that type of substitution of a resolution agonist. And we looked here into effects, preparations of the spinal cord, and in the presence of Marsin 1 treatment, the resolution index can be shortened significantly. And we wanted to know more about how this resolution is propagated. Can we actually also trigger efferocytosis? To assess that further, and I should probably explain more in detail what efferocytosis means. Efferocytosis means basically that a macrophage is taking up another immune cell, most likely a granulocyte, and then package this immune cell for removal from the lesion site. And to assess now for that, one can use FACS analysis, permeabilize macrophages, and then look for whether these macrophages have ingested here granulocytes. We assessed then these spinal cord animals with Marsin 1 treatment, and what we can see here that the amount of efferocytosis cells is increased as a consequence of this intervention. Also, we see lower numbers of macrophages accumulating here at the lesion site, resulting basically in a lower resolution plateau. Importantly, the question comes, of course, whether this is relevant at all, whether this is also translating to different neuroanatomical here features, and this is illustrated here. Propagated resolution allows for a more spared white matter, as here demarcated in blue with Luxol fast blue. This is just a quantification of that, and also this spared white matter also translate into here better recovery in those animals. So I would like to summarize the last part here with regard to resolution. Resolution of inflammation can be an immunomodulatory target also after spinal cord injury, given the fact that resolution is impaired after spinal cord injury and associated with oxidative injury. The gain of function experiment here using Marsin 1 has been shown to be effective even behind the blood-brain barrier, and is able to at least partially rescue impaired resolution. It can boost the immune cell clearance or efferocytosis, and is associated with more spared white matter as a protective effect, and also improved neurological recovery. So the last here sum up is about the clinical relevance of these maladaptive immune syndromes. Why should this be relevant? Well, because these maladaptive immune syndromes can give rise to a second hit. Either this infectious insult, as I was showing you, but also secondary autoimmunity may induce actually a deviation from the predicted outcome, basically resulting in an inferior outcome as being usually to be expected. We see that also as a treatment opportunity, not only basically focusing on agonistic approaches, which are important and which we have done in the past, trying to get more cues to the patient, intensity of rehabilitation. But besides these agonistic approaches, it appears to be worthwhile also to include strategies trying to tackle detrimental outcome modifying factors in order to better here protect outcome at risk. So finally, I would like to summarize. The immune system function needs to be orchestrated all the time to deal with perturbations, complexities, and also, of course, associated challenges. And this is not anymore possible to the same degree after a spinal cord injury. So it's not anymore possible to gather information about the inflammatory state of the rest of the body. Also, it's not possible to instruct appropriate immune responses in time, given really the lack of function of major adaptive sensor systems, such as the autonomic nervous system or the HPA axis. So in other words, the central nervous system is losing control over the immune system, and this results in maladaptive immune responses. I gave you here 3 examples. One relates to impaired host defense, entertained by the spinal cord injury-induced immune deficiency syndrome. The second is impaired discrimination between self and non-self, which then will allow for secondary autoimmunity. And the third one is the impaired resolution of inflammation. So going forward, we would like to help the immune system when it starts to make mistakes in order to correct for these maladaptive immune responses. And we think this also can inform care by development of preventive treatment strategies. And this is by no means specific likely for SCI only, but also could have implications for other acute injury paradigms like it's stroke and or TBI. With this, I would like to close. I would like to thank all the individuals who accompanied me on this journey here in Berlin: Marcel Kopp, Uli Diernagel, Harald Prüß, also all, of course, individuals here in the Schwab lab here at Ohio State, also my colleagues from the Belfort Center, Phil Popovich and Dana McTighe, also my colleagues from the outgoing Spinal Cord Injury Model System Center, and of course all the funding agencies, and a particular shout out actually for CBI, who supported me here tremendously here at OSU while being here on this path. I would then like to close with this image of Sir Ludwig Guttmann. We always stand on the shoulder of giants, and Dr. Guttmann for sure is one of those, indicating very early that spinal cord injury is not just an injury to the spinal cord, but also has systemic implications. And I guess this quote is still a very modern one to this day. With this, I'm closing, and I'm happy to take questions.
Thanks, Jan. Great talk as always. Interesting data. The connection between injury and immune dysfunction is fascinating. We can open up for questions. There's probably two ways we can do it. If you raise your hand, we can have you ask live if you'd like that, or you can type something in the chat. So I guess maybe I'll start, since I have the microphone on and the video on me. So let's say you identify, can you pre-identify somebody clinically who will maybe more prone to this immune dysfunction? Is there something you can detect clinically and then something you can do to treat that, or is that too hard to do?
No, this is ultimately the goal, and I think you can already very early on, within 24 hours, actually during the first day, already identify how deactivated the monocytes are. And then you can, with a 90%, this is actually where we want to go. And I guess it's feasible with a 90% a year likelihood, identify those patients at risk. So we gain time before they develop the infection, basically. However, this will require to do something different than just apply antibiotics preemptively, because these antibiotics do not work preemptively. So we need to be better with regard to understand the mechanisms on why these patients are immunocompromised, and then we can actually be more specific with trying to prevent these infections.
Let's see, do we have any more questions? I guess, Jan, you have so much compelling data that you answered everyone's questions.
Yeah, if there are no questions, of course, and they may arise later, then I'm happy. Oh, Michelle.
Can you hear me?
Yep.
Okay, good. The question I have, Jan, I thought that the interrelationship between neuroimmune cells, infection, all of those things are really interesting to me. And you've introduced ideas about double challenges to the nervous system, not just from the injury itself, but from other challenges like infection. And what I'm wondering is whether exercise or physical activity or rehab is also another challenge, and whether you've looked at that at all, and if there's a time frame for it. So I don't know that I have experience in human spinal cord injury to answer that question. I have seen some relationships, but not enough. I can't put that together from my experience. So I'm wondering what you might know about it, given the information you've shown us regarding time courses and stuff.
So rehabilitation has been tested with regard to altering this immune suppression. And it has been shown that rehabilitation, probably because also training the autonomic nervous system, has been shown to actually improve host defense. Yeah? And so by mechanisms, I think, which are probably not yet disclosed, it's just correlative data, but this is work done end of the 90s actually, and then also Dr. Kruse was involved, and Denise Campagnolo, really this early guard of people studying this immune suppression, have found that if in patients who receive rehabilitation, they are actually doing better with regard to recovering immune cells numbers and function as compared with basically patients who are not actually getting intensive rehabilitation. So the timing, I have to look into these papers, how they did it, but rehabilitation overall can be considered a good effect. If you say, could there be even a bad effect if you rehabilitate too early? I think they didn't look at that, and I think this question is still open.
Can I ask a quick follow-up? There's a big push right now in physical therapy to do high intensive interval training. And most of the data, the support for that is in chronic spinal cord injury, but it is also being adopted in early outpatient. And I'm just wondering what that kind of, and when I say high intensity, that's based on cardiovascular and trying to hit targets that are 80% of the VO2 max or heart rate, 80% up to 100% I've seen in the literature so far. So I'm wondering how that might play in, and those older studies probably wouldn't have that kind of intensity in mind.
No, I'm for sure not. And honestly, I can only speculate, Michelle, but I think, with this kind of challenge of going to 80% VO max, this is quite a strong autonomic stimulus, I would say. And so the system needs to digest a lot. But what to expect? Well, I would still say it will still, trigger a response, probably a beneficial one, in terms of, adapting to this. So I think this would be interesting data to look at.
Yeah, thanks. I was thinking the same thing, that real high intensity might be even a bigger boost. So thanks, Jan. Thanks, John.
Thanks, Michelle. We do have a couple more questions. I'll do Andrea Tedeschi. He wrote one. I'll read it for you. And then we have a hand up, I think, Ginger Yang. So we'll do those two. And then there's another one after that. So Andrea says, great talk. I was wondering whether acquisition of systemic infection during the chronic phase of SCI may increase the risk of developing other complications, including deterioration of mental health, depression, anxiety, etc.
Very good question. Yeah, also, and I didn't show this data just for time reasons. And this is a score Angela Filou has developed. This is a sickness score. Of course, with these infections, we see sickness behavior, and these animals are tremendously sick. In the chronic condition, we didn't yet do the complete set of experiments yet, but also here you have to consider that, of course, the blood-brain barrier is still not fully healed, and then a systemic infection is, of course, able then to also to generate endotoxins, which can go into the CSF and then also trigger fatigue depression and this kind of sickness behavior like phenotypes. Very true. So it's clinically, it's already known that if a patient with infection comes in, that most likely they will also have, you know, exuberant spasticity all of a sudden. You know, patients who have been okay with their spasticity, but when they get a UTI, they have a profound increase of spasticity. So you can see all kind of changes there, indicating that there need to be a change here directly also at the hardware itself. It's not just a peripheral insult. If you get this kind of increase in spasticity, this indicates there's more lack of inhibition, basically. So just by that, actually, one can conclude that, yeah, also depression, others, you know, this is not a protected system anymore.
Yeah, great question. I think we have, yep, Ginger.
Very good presentation, although a lot of things I don't know, but I may ask a very naive question. I saw you have you do clinical trial with the patient. You also indicated you trying to understand the causal relationship. So you actually did the animal model. So my question to you is, do you have the collaborator, or do you how you structure? Like, I know the expertise can be different. Of course, maybe you can do all of them, but how you actually do the both human, like the work with the human, but also use animals work to support your work with treating the patient, maybe the question feeding to your animal model.
Right. Yeah, I think it's not at all a naive question. It's on how to get, I guess, towards phenotypes of associated with outcome. And I can just answer how I do approach it. Of course, I'm a physician scientist, so I guess I speak both tongues, you know, from the lab and then also in the clinic. But it was really by intention. I saw so many clinical trials failing in stroke, you know, which of course mostly are about neuroprotection. And this is where I was trained, a big stroke clinic. And what they learned is actually saying that probably we should not just use a gene knockout or whatever, you know, where just one gene is modified, and then the closer we get to clinical testing, the more redundancy of these genes is actually, if this gene is popping up, and then we end up very likely again with a negative clinical trial. So by contrast, this is what has been learned, is saying probably start on the clinical side first, and then identify a phenotype which is associated with impaired recovery, for example. And then you work backwards to the animal model, try to understand the underlying mechanism. And then if you have a mechanism, you can then, of course, develop clinical trials. But this is the real thing. You cannot get lost in translation because, you know, the phenotype is already there. So this has instructed me, and how to do that. Well, yeah, I guess it's a lot of work, and I have been fortunate to have great people to work with in Berlin. I still work with them, and they work on the clinical phenotype side, you know, doing this large data analysis. Basically, this is epidemiology. And then here in Ohio, I have the fortune being fortunate with a group of people to work with the animal model. So I can complement basically the two things. I can identify phenotypes, and then also with the animal model, I can identify then underlying mechanisms and possible targets for intervention.
Thank you so much.
Great. We have two more questions in the chat. I'll read them. First one's from Anna Ratted, and she says, how would you prevent or minimize autoimmunity?
Also a good question. So to be able to reduce or prevent autoimmunity would preclude that we know why these patients are developing autoimmunity in the first place. And it might be, indeed, this is just now observational data, that indeed these patients with lower lesions, which are not so much immunocompromised, are also the ones who more likely develop autoimmunity. So they are at higher risk, probably likely because there's not such a profound immunodepression. So how can we modify that? Probably not much, because this is the lesion as it is. Another feature we would like to know more about, and I guess CBI might be also interested also to join that type of expedition, but it's an adventure to learn more about, you know, the T cell receptors and B cell receptors repertoires, which may be different in those patients who develop autoimmunity compared to those who do not. And this is, I guess, the way going forward, characterizing those patients. It's about 15 to 20% who will develop autoimmunity, and looking more on T cell and B cell repertoires, how they look differently. And we know from MS already, not everybody with a not everybody will get MS, so there's a genetic predisposition there too. You know, we can even learn from MS to see what kind of predispositions are there genetically already encoded to make autoimmunity likely. So we will look also, of course, need to look for these genetic loci and see whether they are also being present in those patients in SCI as well. So this is the way going forward. Can we prevent autoimmunity? Yeah, I don't know. Honestly, I don't know. And if it's relevant, and I should be, you know, also be very clear, the autoimmunity being identified as really negative, you know, this was the work, fantastic work by Phil Popovich. I showed this his paper in JCI 2009. This was a long time ago, pioneering work, and here he could really say that these antibodies are likely negative overall. We don't know yet what these antibodies in human spinal cord injury are. They all negative? Maybe some of them are protective, even, you know, natural immunity. We do not know yet. You know, we're just starting into that, and more to come, I hope.
Thanks for the question, Anna. We have one more. Fernanda Franca asks, how do you think we could tackle inflammation in the spinal cord without doing more harm than good by decreasing the inflammatory response systemically and making the organism even more susceptible to infection? She says, maybe using local drug delivery systems at the spinal cord.
Yeah, also a very good question. Maybe even referring to high-dose corticosteroid treatment, which has been an option, you know, for spinal cord injury early on. It has been, however, is not continued. But what we saw in these patients getting high-dose steroids with the idea to reduce, you know, cellular vascular edema, that these patients also indeed developed more infections. So indeed, systemic immunosuppression may be not a good idea for immunocompromised patients, as they will pick up more infections. So what should we do, or could we do instead? I think, and this has been introduced here, maybe we are just not really well advised to treat anti-inflammatory in those patients, but we can still treat pro-resolutive in these patients. So where we actually try to not block the entry of cells into the lesion, but we can try to remove, we can try to perpetuate the exit of the inflammatory cells from the lesion site. And this is a complete different class of drugs, and which are also not immunosuppressive. So this may be a way going forward. Let's see how this will play out.
All right, great, Anne. Thanks again for awesome presentation, and thanks to all the audience for participating and being here. We have, you know, this is something that we do quarterly, and so our next one will be, where is the date? Will be Ginger Yang on February 17th at 9:30 a.m., another Friday lecture, so tune in for that as well. But thanks again, everybody, and have a great weekend, and we'll see you next time.
Have a good one. Bye-bye. Thanks for the questions.
Yep, thank you.